Hi everybody, welcome to this webinar that we're hosting. It is now the afternoon, so it's almost time to get going. We're just going to give people a couple of minutes just to filter in from the waiting room. We've got about 200 people registered for today's webinar, so that's great. As you know, the report was published last week, so what we're really looking for today is lots of interaction. So I'm going to mute myself for a minute or so just to let everybody filter in, and then I'll do a proper introduction and we'll get going. Okay, so we're officially at 12:02, so I think we should probably get started. So I'm Lindsay Pearce, I'm the chair of the National Emergency Laparotomy Audit. Delighted to have today as well Dave Saunders, who is the anaesthetic clinical lead nationally, Angeline Price, who is the nursing and AHP lead, and Edwin Clark, who is our surgical lead. Also lurking in the background is Christine Taylor, who is our project manager, who many of you have probably had interactions with through the NELA email address and with any inbox queries. What we're looking for today from this webinar is that Dave will rattle us through the findings from the 10th annual report. We're going to then have quite a nice, hopefully slightly prolonged session of question and answers. It's difficult when we haven't got everybody's faces on the screen and we can't see you, but we have got a Q&A feature within the Zoom webinar. And I'd really like you to use that to give us any thoughts or comments as Dave's talking, any points that you'd really like bringing up for discussion on the panel at the end. We're going to have plenty of time, I hope, to have that conversation. So I'd really like to have that that interaction with you throughout this webinar. If you have any problems during the webinar, just leave and rejoin. Sometimes IT does fail us. But without further ado, Dave, I'm going to hand over to you to present the findings of the 10th annual report. Thanks.
Thank you, Lindsay. Thank you for the kind introduction. Thank you everyone for dialing in. I'm aware this is not in the correct view on PowerPoint, but hopefully you'll bear with me. Okay, so this webinar is around the 10th annual report. We published this last week. As Lindsay has said, just make sure this works, please do ask any questions as you go along. Either today, now live, ask the questions and we'll do our best to answer those, or feel free to email either me personally, or perhaps even easier is to use that inbox email address that's at the bottom of most of these slides. So I'll just start with the headlines from the Year 10 report, because many of you will have followed the 10 years of annual NELA reports in the past, but for some of you, this might be the first time you've gone through one of these reports. So in a moment, I'm just going to give the briefest of backgrounds to what this whole program's about. But the Year 10 report covers the period of clinical care patient admissions between April 23 and April 24. So it's already slightly out of date. 23,500 patients were registered from England and Wales. Headline outcome measures, post-op length of stay fell back from 11 to 10 days. So that's positive news. And mortality fell from about 9% to 8.1%. So more positive news. Okay, so this is what I'm going to cover. Some important notes regarding year 10 of the audit. I think it's really important to get your heads around that, because although we've been talking about it within the project team for a little while, it may not be widely understood that lots of the measures we audited against were changed for this year. I've got some data of process measures, outcomes, a little bit about health inequalities, and then hopefully, as Lindsay said, some Q&A. So this particular year, the audit targets we adopted, they were tougher than had been previously used. And it was also a tough year clinically, and I think that continues, doesn't it? But that year was when the NHS was in the news weekly with long queues of ambulances outside emergency departments. Year 10 was the first time we particularly tried to focus on what I've called here the bookends of the pathway. So NELA has concentrated traditionally on the immediate perioperative phase of a patient's journey through the hospital. But for this particular year, we started to focus more on what we're going to call the diagnostic pathway leading up to a decision to operate or leading up to getting to theatre, and also looked more closely at the post-operative phase of a patient's admission. There's a common theme through lots of the findings about variation. So the standards of care a patient receives and their outcomes varies dependent upon where they have surgery. And I'll emphasize some of that in some of the data. Okay, so year 10, please note, we revised the standards we audited against, and they're tough. Really important is we adopted a categorization of patients that is applicable during the diagnostic phase of their admission. So the RCS guidance that we take a lot of our standards from, published in 2018, they categorize patients, sort of unfiltered general surgical admissions, into an immediate group, a non-immediate group, and a non-operative group. So the RCS immediate category, this is for patients with common but serious suspected diagnoses such as peritonitis, perforation, tender bowel obstruction, suspected ischemia, hemorrhage, or sepsis of a surgical origin. And the clock starts from an audit perspective with the time the patient presents to hospital. And it's important to get your head around it. It's the underlying pathology that defines the urgency through that diagnostic pathway, rather than traditionally what we've taken the clock start for making judgments about timeliness of care. The clock start was really at the point of decision to operate in previous analysis. Also in year 10, we updated the risk score. We're now using what we've called the parsimonious risk score because it uses just 13 variables instead of the previous 22. We adopted the presence of a frailty assessment as an audit standard. And we also adopted frailty, the presence of frailty, as an independent variable that defines a patient in the high risk category, high risk of serious complications after surgery. So this is the RCS immediate categorization. It's tough because it says that patients should receive definitive management within 6 hours of presentation. This is not quite the same as the NCPOD immediate category, which is defined, as I just said a moment ago, at really the point of decision to operate. Okay, so we'll jump straight into some of the findings, and I'm not going to go through them all, but picked out some of those that might produce more debate and questions. So I think this is overall a very positive message. CT scanning and reporting, almost invariably, every hospital can provide urgent and out of hours CT scanning for patients that require it. Our standard is difficult because there's 3 composite parts to it. The first bit we say, was the CT report delivered by a sufficiently senior radiologist? And the answer is yes. Almost invariably, when a CT is done, it's reported by someone that is experienced in reporting abdominal CTs. We ask about the timeliness of the report. So was this delivered within 1 hour of the scan? And I personally was quite impressed by that. I think this is quite impressive that on half of occasions, departments of radiology can provide a provisional report within 1 hour. And the third component to this composite measure is we ask for this particular group of patients that have got suspected serious pathology at presentation, was there evidence of direct communication between the referring and reporting clinical teams? That's a much lower proportion, around about a quarter. So when you add together all the shortfalls, potential shortfalls in those three composites, that's why overall performance appears to be very poor. Just 12% of patients met that audit metric. But this communication bit, we believe this is really important. And I've just split here the proportion of patients where there was evidence of direct communication by phone or in person between patients where CT reporting was done in-house or where it was outsourced. And there's a difference in the ability of referring clinicians to be able to talk through the findings of a scan. Okay, second clinical arena, if you like, infection management. So we know this, there's two parts to this: expeditious use of appropriate antibiotics, and for this particular group of patients, definitive source control, which means getting to theatre. In year 10, we tried to differentiate between different degrees of infection. So we've called that patients where infection was suspected, patients where sepsis was suspected, and patients where septic shock was suspected. So a sort of spectrum of physiological response to the suspected infection. The timeliness targets for antibiotic administration varies depending upon how sick the patient is. This is a change from the previous surviving sepsis campaigns where it was basically 1 hour across the board, but a more nuanced approach in 2022, the AO-MRC antibiotic guidance softened the timeliness target for commencing antibiotics to 3 hours for patients with suspected infection. But if sepsis with physiological disturbance is suspected, antibiotics should still be given within 1 hour, and the same applies for septic shock. The median time to commencement of antibiotics, actually for those with lesser degrees of infection, on about 50% of the time that target is met, but 25% of patients wait about 6 hours or longer before antibiotics are started. When sepsis is suspected, again, 25% of patients waited almost 6 hours or longer until antibiotics are started. And even in patients with septic shock suspected, 25% of patients waited at least 4 hours until antibiotics were commenced. These charts, of course, you can't see that these are all the hospitals that have contributed NELA data. So on the left, this is the proportion of patients that met timeliness targets when suspected infection was present or suspected sepsis on the right. The red dashed line I've put in is the 50%. So almost all hospitals struggle to meet that 3 hour target, and they certainly struggle to meet the 1 hour target. But there is variation. Some hospitals do this better than others. Definitive source control for infection management. The timeliness target here, the patients with suspected surgical source of sepsis, they fall under the 6 hour category, the RCS immediate group. So patients should be in theatre within 6 hours of arriving at hospital. Divided the patients up here into suspected infection, sepsis, septic shock. And the answer is, on the whole, this just absolutely appears to be not possible to get patients to theatre within 6 hours with current resources. The proportion of patients that meet that 6 hour target, it improves as their sickness severity increases, but these are small proportions of patients. In terms of, have I got that? Yes, I have got that. So this is, again, a spread of all the hospitals that have submitted data. There's the 50% marker, and all hospitals appear to really struggle with this 6 hour target. The median time for this group of patients with RCS suspected immediate pathology arriving in theatre, as I say, there's a 6 hour target. If you're admitted under general surgery, the median time until getting to theatre, 19 hours. If the patient comes in under general medicine, 66 hours. I don't think for 1 minute these are the same groups of patients. I'm sure that some that are admitted under medicine have other comorbidities, or perhaps inflammatory bowel disease patients that come in for medical management of their condition and eventually are transferred across to surgery. But there is food for thought here about this discrepancy, and there's a QI box in the report recommending that local sites review patients who end up in NELA that were originally admitted under medicine and go through their case records to see if there are any lessons to be learned. Okay. Risk assessment, let's have a look at this. I mentioned this in the introduction. So NELA defines high risk of mortality, post-operative mortality, by any or all of 4 different methodologies. The first is a formal calculated risk score, the parsimonious risk score of 5% or greater. So it's a slightly arbitrary line in the sand, but being 5% is taken as high risk. Regardless of what the computer says, if the clinician ticks the box to say, I believe this patient's at high risk, that puts them in the high risk category. If they have frailty, defined as a clinical frailty scale of 5 or greater, I might come back to that in a moment, that puts them in a high risk category. But we also take a patient where there is a lack of any form of formal risk assessment. We default to a position of that patient is at high risk of mortality. So lack of risk assessment does not equal lack of risk. This is a success story, I think, from the NELA program. It's pretty well delivered this year on year in a large proportion of patients, and overall 81% of patients in the registry had a risk assessment done. We have taken just under 53% of our registered cases, that was 23,500, as meeting one or more of these high risk categories. That's the spread. So it's apparent from that some hospitals have put in place systematic, reliably delivered systems of formal risk assessment or a form of risk assessment prior to theatre, but other hospitals have been unable to introduce that. The frailty assessment, I think this is really interesting. So it was about just under 13,000 patients aged 65 or older. A good proportion of those did have a frailty assessment done during their admission. 40% of patients of those aged 65 or older were deemed to be living with frailty, defined as a CFS of 5 or greater. That's this middle row here, so 5, 6, 7, 8, 9, increasing levels, degrees of frailty. The observed mortality here, 15%, 20%, 24%, 39%. So really high risk if the patient's living with frailty. Just want to draw your attention to this group here on the CFS score would be categorized as vulnerable to frailty, also a 13% mortality risk. So being vulnerable to frailty is also significant. A bit like I said, lack of risk assessment does not equal lack of risk. Well, lack of frailty assessment also does not equal lack of risk. At the top here, this is the proportion of patients aged 65 or older who did not have a frailty assessment recorded, about a quarter of the patients. Their observed mortality, 11%. Okay. Let's look at some post-op process measures. Critical care. This has not changed. We audit against a standard that says high-risk patients should be admitted directly to critical care post-operatively. In year 10, just under 80% of high-risk patients were admitted to critical care. In this table, the different rows are different placement decisions made for patients. The right-hand column shows the high-risk cohort. So, as I said before, 12,390 patients. Down here, there's the 77.6% of high-risk patients went to critical care, but 16.9% of high-risk patients went to the ward. Just want to draw your attention on this table to this row here. So the left-hand column, this is the low-risk group. 30% of low-risk patients went to critical care. And I think that's a really interesting thing to discuss when we can. This shows the spread of performance about the standard where high-risk patients go to critical care. Again, it shows that many hospitals are reliably delivering this week in, week out, but some hospitals at the bottom just cannot do this. They don't have the resources. I've put a line in the report that we estimate there are about 61 NELA eligible emergency laparotomies per 100,000 adults per year. If we estimate that half of those patients would be categorized as high risk, we can estimate that per 100,000 adults served in your local population by your hospital, you would expect 30 to 40 critical care admissions if we were to meet this standard. So that might be of use in commissioning discussions. What about the low-risk patients that are admitted to critical care? I've just pulled this out. I'm not an intensivist, I'm a theatre anaesthetist, but my critical care colleagues are always very interested in this, and I think it is worthy of discussion. So on the left, we've got the low-risk patients. On the right, the high-risk patients. We've got the total post-op length of stay, but importantly here, we've got the median critical care length of stay. So low-risk patients, a median critical care length of stay of 3 days. Anecdotally, I suspect that a lot of this is the patients have got into critical care and then cannot get out because the ward is full. I don't believe that there are many critical care interventions required for a lot of these patients. So I think that is food for thought, especially in hospitals that are struggling to provide critical care resources for their high-risk patients. And it's, to me, this is about that risk stratification. But I'll just express a personal view as well that our jobs as clinical staff is to ask for the resource. I understand we are juggling all the time, but if we don't ask for the critical care bed, then it definitely won't be forthcoming. That's why I see my role as the theatre anaesthetist, is to advocate for that patient. I will ask if it cannot be done because critical care is full, that's fine. We'll review perhaps in theatre and at the end of surgery and revisit the discussion at that point. Okay, so the further end of the patient pathway, let's look at specialist care for older patients. Some important findings here. So the standard we audit against is the proportion of patients aged 65 or older and living with frailty, or anyone aged 80 or older who received post-operative assessment and management input by a member of the perioperative frailty team with expertise in comprehensive geriatric assessment. So that slightly cumbersome definition was adopted from the previous statement that talked about input by a geriatrician team. And this wording was deliberately chosen, the perioperative frailty team, to enable perioperative physicians, as long as they have backup from expert geriatricians and they themselves can deliver some expertise in comprehensive geriatric assessment, then that would meet the standard of care. So I told you this before, 75% of patients over 65 had a frailty assessment. The majority of those were living with frailty or vulnerable, one of those two categories. 35% of this group received specialist input post-op. Does it make a difference? So these different rows show different ways we've sliced up this population age 65 or older, and with or without frailty. So there's everyone age 65 or older without frailty, everyone age 65 with frailty. So there's different ways of slicing up the population. And then we've looked at observed mortality. And this right-hand column shows mortality when no specialist review took place, and the left-hand column shows mortality following specialist review. So however the population is divided up, at each stage, observed mortality is strikingly lower when specialist review took place. And it's an association. It, I guess, doesn't prove the cause, but it's a striking association. Now, previous NELA reports, we've then looked at length of stay, dividing the population up into whether or not specialist input was delivered to this vulnerable group of patients. And we've shown that length of stay was actually longer when the specialist care was provided. The problem with that analysis, with that association, was that they're almost certainly different groups of patients. So this year we tried to look at it in a slightly different way. And if you'll just bear with me while I explain what this shows. So we've categorized hospitals into those where I'm going to call it systematic specialist care can be delivered for older patients. So high rates of review, 75% or greater. And those hospitals that have a more traditional, I'm going to call it reactive geriatrician input with lower rates of review for older patients. In the hospitals that have a high rate of review, the overall median length of stay is lower by a day than hospitals that have lower rates of review. If you subdivide those hospitals, so in the low rates of review, was the patient seen by a member of the specialist team, yes or no? The patients seen have a longer length of stay than the patients not seen. But again, these are almost certainly not the same groups of patients. The ones that are seen, especially in a hospital that has a reactive system, these are much more complicated, more vulnerable patients with all sorts of reasons why they can't be sent home. Whereas there are other older patients that sail through and no elderly care review was necessary. And needless to say, they then have a shorter length of stay. But I think that finding is really important. So it undermines the previous, well, it doesn't undermine it, but it reassures us that investing in better specialist care for older vulnerable patients is cost effective. It probably shortens length of stay. It certainly does not prolong it. Final couple of outcome measures. Post-op length of stay, it's fallen a little bit, which is nice to see. From 11 days in last year's report to 10 days. Not going to pick this out, but the point of this caterpillar plot is to just demonstrate that post-op length of stay varies depending upon which hospital the patient's in. So some hospitals have a very short length of stay and others much longer. These hospitals, we know, are not directly comparable. Some hospitals will have very skewed specialist case mixes. Some have an emergency department, some do not. But I think the point about variation stands. There is wide variation in the ability of hospitals to engage with enhanced recovery after surgery programs for emergency patients. Mortality, like I said at the beginning, that's fallen to 8.1% from 9% in last year's report. So that's always nice to celebrate that, especially taking into account just how stretched things are within the NHS in 2023 and 2024. That run chart shows the 30 and 90-day mortality over the duration that the NELA program's been running, so a nice reduction. The right-hand funnel plot, that's within the year 10 report. We can see there's the median at 8.1%. The point of me showing this to you there is that there is wide variation. So once again, some hospitals, and this data, by the way, this is adjusted to take into account sickness severity. So some patients have some hospitals have a very low risk-adjusted mortality, and other hospitals it's much higher. All of this data pertaining to individual units, that's contained within the RAG table, a big Excel spreadsheet that's got data for each hospital. That's available to download alongside the totality of the report. I think this is almost the last slide I've got. Health inequalities. We've looked at the population by deprivation quintile in both England and Wales, and that's available for you to look at. This we found really quite interesting. Almost by accident, this analysis has come to light just looking in more detail at potential health inequalities. We've looked at a basic division between female and male patients. So for most of the process measures, no differences, I'm pleased to say. Consultant presence in theatre or the radiology metrics appear to be uniform whether or not the patient's male or female. A slightly greater proportion of high-risk male patients were admitted to critical care than high-risk female patients. And this is an important finding, that female patients appear to have a more prolonged pathway from arriving at hospital until they get to theatre. That's demonstrated in this data at the end here. For female patients in the RCS immediate category, the median preoperative time until they arrive in theatre, 23 hours compared to 20 hours for men. The proportion that meet that 6-hour target is showing the same data in a different way. For females, 6.9%, for males, 9.9%. So my conclusion is, I think this is a real finding. I don't think we know why this is. So I think at this point we should probably open the floor up to Q&A. I hope I provoked some questions from you. Please do keep sending them in. There are some key messages within the report that by the sort of commissioning requirements of the report, the key messages are meant to be upward facing. So rather than directly to clinical teams around the country, these are to commissioners, NHS England, the Welsh Government, but the themes are absolutely clinically relevant, and it's around what I've tried to highlight in going through some of the slides. It's around timeliness of care, this message about direct communications between referrer and reporter following CT scanning. We've got some evidence of shortfalls in critical care bed capacity in some hospitals. We've got evidence that specialist care could be more reliably provided to older patients, and that would not only hopefully reduce mortality, but also be entirely cost effective in terms of length of stay. And importantly, at almost every measure we look at, there is wide variation in the ability of hospitals to provide the best standards of care to their NELA patients. Thank you very much.
Brilliant. Thanks, Dave. That was really clear. As I'm sure everyone that's dialed in can imagine, and there are now 115 people dialed in, so I'm hoping the Q&A is about to ping. That we get an enormous amount of data, don't we, when we look at these annual reports, and it's really hard to know how to slice and dice this data in a meaningful way, not only for patients and their outcomes, but also for clinicians and the things that the clinical teams are interested in or may be able to improve. Because at the end of the day, we're all interested in trying to invest in the right places to improve care and outcomes. So there's a few different bits that Christine, I'm going to rely on you to ping the answered questions out of the Q&A, if that's okay. But before we get started on the Q&A, I'm just going to let some other questions come in. So I just wanted to pick up on the timeliness thing. So you described about how 22% of patients with septic shock are getting to theatre in 6 hours. So they are our sickest patients, and yet we're not able to get them to theatre within their appropriate timescale. Is that because we are failing to recognise those patients as being so unwell, or is it that we're failing to get people to theatre? What do you think, and how do we address it?
I guess you're asking me, Lindsay, because our audience can't speak. So I can express a personal opinion.
They just have to type instead of speak. I'm asking you initially on your thoughts, and then we'll see if anyone pops into the Q&A.
So I think it is really interesting. If you look at it the other way around, no patients leave theatre without having received antibiotics. It's such a firmly ingrained part of the WHO check-in process, which of course, a lot of that has evolved around the prevention of surgical site infections. But we need to remember now we've got a group of patients who have some kind of intra-abdominal, I was going to say catastrophe, or certainly a very serious pathology, if not a catastrophe, where infection is an enormous part of what makes that patient so poorly and increases their risk of not surviving this illness. So it's really important, I think, that once the penny has dropped that this patient has this potentially serious pathology, the antibiotics are commenced immediately, prescribed, administered. And I think that in a perfect world, we would have a debate about the point at which, so those antibiotics probably should have been started even before the definitive diagnosis has been made. So as soon as infection or sepsis, and certainly septic shock, is suspected, antibiotics should be commenced. That all the time is playing off with the antimicrobial resistance the absolute importance of that, and the fact that patients that end up in NELA, they arrive at hospital without a neat label and diagnosis, and they come in with non-specific symptoms and signs, and there is a degree of what I'm going to call processing, which is probably an unfortunate phrase to use about our fellow citizens, but a degree of processing needs to happen within the healthcare system until a definitive diagnosis and management plan is made. But at some point during that processing time, it's really important that somebody thinks this could be something serious. I'm going to start some antibiotics and then hopefully de-escalate them. I don't know if a microbiologist speaking would be as comfortable with me saying it so bluntly. I hope they would. I think they would.
Yeah, absolutely. Yeah, definitely. Okay, so there are a few things that have popped up in the Q&A. So let's wriggle our way back up a little bit. I think it was a lady called Helen somewhere. I think she might have been moved into the answer bit, but Helen had put on, is there a way of sort of sharing practice with the well-performing sites? So some of that hospital variation, perhaps we could try and pull out some of the sites that perform really well in their timeliness standard and maybe invite them to a webinar presentation around their processes and how they do it. We have done that before, but we've done it more for the positive outliers, not really looking at individual metrics. So maybe if we're picking out this timeliness is a real issue, we maybe need to think about doing that as a project team. I think that would be good. Moving on.
Lindsay, shall I just say something to that? Because
Yeah,
it goes through my mind. I have a feeling what we would find is that there are hospitals that have specialist nurses. There are some who've invested in a NELA nurse,
yeah.
and I have a feeling there will be a big overlap between that group and the hospitals that are able to process patients quicker and make a decision.
But then what a great argument for organisations to say, look, we need to invest in these patients to improve timeliness metric and potentially improve their sepsis treatment metric as well. Because what we're trying to do is avoid that variation. The variation that we can't avoid is the variation between those centres that are completely cold elective sites who have returns to theatre that come into NELA and those that have got a front door ED. They are quite different beasts, I think. Just to pick up on the CT element, Natarajan has said it's difficult to see a documentation of CT report communicated between surgeons and radiologists, and that was something that I was going to pick up. We haven't said as a project team how we want this to be documented to be able to be picked up. We're just asking the question. So maybe we need to think about how sites might be able to clearly document that. Should it be on the CT report? How do you think sites would best be able to pull that information out and make sure it goes in their data set?
So I think this standard is, for some, it is slightly controversial, and it's quite, there's not very much nuance to this RCS immediate categorization. For example, the inclusion of tender bowel obstruction in that group, but non-tender bowel obstruction in the non-immediate group. Nevertheless, we've done our best with the information we're given, and when tender bowel obstruction was ticked, we put them into the RCS immediate group. I suspect that not all of those cases need that direct phone call, but many of the patients would benefit from that. If a serious finding is found at CT, why would you not pick up the phone and push that information?
Yeah.
I'm sure that's what goes on in cancer MDTs. In fact, there's a radiologist in the room and the decision making is done. During the day, I mean, I'm not a surgeon, Lindsay, you are, but during the day, I know my surgical colleagues will come to me in theatre and say, I've just had a chat to so-and-so down in radiology. We think this guy's got a perforation or whatever. So during the day, that direct communication does go on. Why should it not go on out of hours? It might be that it does go on more than we realise, and it's just not documented very well. And what I've seen locally at the RVI is the provisional CT report, often done by a registrar, but at the bottom it says findings, telephone to surgical team or to the emergency physician.
Yeah. Okay. So there are two elements out there. Either we're being reactive to it because somebody in radiology is phoning us directly, or we're physically going to find a radiologist to discuss it. And either is fine, but it needs to be clearly documented. And the clinical audit teams who are populating data or clinicians need to know where to find that bit of information. Edwin's got his hand up. I'm going to come to Edwin, and then we'll move on to a different topic from Q&A.
Hi. Yes, I was just going to add to that I think it will vary between trust to trust as to what the documentation of discussions will be. Some, as you say, will be documented on the radiology report. Some will be in the case notes. We know that there's a large variation between units as to whether they have a easily accessed electronic patient records, and some will have written records, and it can be quite difficult, and it's probably reflective of there'll be more direct communication than we'll be able to capture on the audit, I think.
Okay, right. Bear with me for 1 second. I'm just okay, now there's a bit. So Sally Ann Wilson is on. Sally Ann, hello, good afternoon. She's our CRG rep for RChem, just been appointed vice president, I think. Sally's highlighted there's a real difficulty at triage. So they wait for hours for clinical assessment and poor timelines. It'd be great to do a deep dive into ED pathways of those sites with very good mortality results. So maybe that's something that we need to think about for a webinar. And somebody else just popped up. Would triaging nurses at the front door of ED be able to highlight through a clear code, or even able to prescribe the antibiotics within an hour for within the first hour for septic patients? Would that help? So could nurses on the front door of ED be able to prescribe antibiotics? Angeline, you are our nursing and AHP lead. What do you think about front door ED nurses being able to prescribe antibiotics?
So I think, yes, in theory, we've got a sort of population of the workforce who can take on some extended and advanced level skills. I think we've got quite a huge variation across the country at the moment in terms of what people are doing at a local level. So I think it's a piece of work that we need to look at a national scale and see where we can make improvements with this.
Okay.
So I just wanted to draw attention, we already touched upon the specialist nurses. I have a colleague who works up in Northumberland who is a NELA nurse practitioner. He bases himself in the ED department. He scans the patients who are arriving, picks out the ones who he thinks are going to be NELA appropriate patients, and he gets the ball moving pretty quickly in terms of undertaking an assessment, prescribing any antibiotics, ordering scans, and more sort of mobilizing the surgical team. So we know that this can happen well in certain areas, and I think we need to learn from each other and see how we might implement that in different settings.
I guess it takes you have to take into consideration though how you know, the number of patients that are coming through, because not every ED department is going to be able to do that, because they're just simply not going to have the workload. So there is probably an element of education and training, isn't there, for our ED nursing colleagues or non-medical prescribers down in ED to be able to recognise these patients quickly?
Yeah, definitely. And I think sort of part of the work that Guy's done is to arrange red flag type pathways where if there is a suspected patient who might need an emergency laparotomy, that gets highlighted quickly and people get drawn into that pathway. So yeah, alongside the education and training. But I think another important point is not all trusts allow all members of the MDT to order scans and prescribe, etc. So yeah, it's a complex
variability
situation.
there, isn't there? Devika has said the funding from specialist nurse, NELA nurse, where does that come from? I guess that comes from business cases within individual organisations that are able to demonstrate that there's a clear improvement or potential clear improvement in pathways and patient outcomes with these roles. But I think you need to be really specific about what that individual is going to do. Do you think?
Yeah, I think so. And it's picking some of the metrics that locally will get the attention of the people who are making the decisions. So finding out what's important in your trust, i.e. what are you doing well on within NELA, what are you not doing so well on, and trying to draw on that aspect, really.
Yeah, okay. Debbie Phillips has said, just going back to radiology, RCT reports say flag to referrer, but if you're entering NELA retrospectively, it's hard to know what that means. And I think that probably is the case around lots of organisations, that it's hard to interpret what that actually means. So maybe you need to speak to your individual clinicians who are making those comments and make sure that they need to make it absolutely clear. I think the other thing that you're saying, interestingly there, Debbie, is entering NELA data retrospectively, and we've never said whether it should be done prospectively or retrospectively. We assume that a lot of it's done retrospectively, but we are going to start looking at when the data records have been created, just so we can kind of work out in terms of timescale how long around the emergency laparotomy time to surgery itself these records are being entered, and then maybe we can look at the information that's being entered and how it might be done better. Right, where should we go to next? Ben.
Lindsay, there was a I saw a question, a very sensible question about the health inequalities thing about female patients taking longer
we'll
to
come
get to
on to
theatre.
that. We'll come on to that at the end, because I think there's going to be quite a few about that, I think, and that deserves a bit of conversation. Ben Box, hi Ben, he said, do we know if there are particular conditions that are more prone to failing the 6-hour target, e.g. the elderly patient with a strangulated femoral hernia admitted with coffee ground vomiting under the medics? So maybe that's a way that Ben would like the data sliced and diced. What do you think?
I couldn't answer it, Ben, because we haven't looked at it in that manner. Part of the
But the question is about a lot of this data that we're presenting. What is important? If this is the sort of information that you want to see that is useful to you as a clinician, then tell us. Email us at the.info@nela.org.uk, email Dave, email me, any of us. Let us know what you would like to see, because we're starting to think about writing the Year 11 report now. We've only just published Year 10, but we're back on it again with Year 11. So if there is particular data analysis that you would like to see, we can try and include it in Year 11. We'll do it as a subgroup analysis. Okay, right. There was a question right at the beginning. No, that one's gone now. Hang on a sec. Can you repeat what you said about geriatric assessment and how that's changed?
Yeah, okay. It's a bit of a mouthful, wasn't it? So the standard used to say that it should be a member of the geriatrician team. Even that wording was carefully chosen to permit a specialist nurse when working under the or a registrar working under the supervision of a consultant geriatrician. So it didn't simply say consultant geriatrician, it was a member of the geriatrician team. That was amended to a member of the perioperative frailty team with expertise in comprehensive geriatric assessment, which in my experience still largely does mean a member of the geriatrician team. But there are, however, some perioperative physicians who might be anaesthetists in their background that do have the expertise to deliver this standard of care. And that's why the wording was amended. The best practice tariff, if you work in England, that financially incentivizes the delivery of this service for this group of patients, and the wording that we ordered against was taken from that BPT wording. So the enhanced tariff is payable as long as the clinician has the requisite skills. It doesn't matter if they're a geriatrician or an anaesthetist.
Okay.
I hope that answers that.
Thanks, Dave. Right, on that very similar note, Dr. Mark Johnston, who is POPs lead for Liverpool, has said, thank you for including specialist review for older people as a key recommendation. He would be grateful if we could highlight to delegates that if they need support enhancing this further, to liaise with the British Geriatric Society POPs team. He's more than happy for people to email, and they will point you in the right direction to supportive colleagues and resources. So there we go. So geriatricians are very much engaged with NELA and very supportive, and are here to be able to help you. Ahmed Mortada said, I'll appreciate if we can highlight the significance of NOLAP. So NOLAP was not included in Year 10, but we are also writing the first NOLAP report at the moment, and that will be published, we think, in April next year. So NOLAP is obviously another arm to NELA. It is still mandatory under the audit data collection. I know that we've had a few emails from trusts saying that they're really struggling to collect NOLAP and that they're not going to do it, and we've tried to reply in a very supportive way, but essentially it is mandatory to collect that information. So we're appreciative of the difficulties that you're having in trying to get those cases into NELA. If you do need any support, help, advice, there are things on our website to help you, but also please, again, just do email the info@nela.org email address, and we can try and support you. Right, now, what time are we on? We're on 12:50. So the last 10 minutes I'm going to devote to the health inequalities section, if that's all right. Oh, Edwin's got his hand up. Edwin, just before we move on.
Thank you, Lindsay. I was just going to sort of reiterate the message that you had been previously talking about, and some of the attendees had raised as some of the direct questions regarding difficulties in ED, difficulties surrounding caveat assessment, some of the potential aspects of health inequalities which we don't actually have the answers for. However, NELA is such a wonderful tool that does allow so much or the acquirement of so much data that if people are interested, there are various, relatively straightforward collaborative things that could be done. And if people have got an interest, then contact us that we can try and coordinate things. So please get in touch.
Brilliant. Thanks, Edwin. Right. Christine, there's one for you about, do we have a single document that has all supplementary tables and figures? Could you answer that while we move on to the health inequality stuff? Right. So we've picked this up in previous years around health inequality. So there are a few comments. Hang on a minute, I've occluded my screen with the chat. There we go. Right. So Amit Mandal says women are more stoical than men, hence slightly longer delay to theatre. Whether or not that's true, we don't know. We haven't got the data to suggest that, but all we have is that female patients wait longer across all age groups. It's been consistent, and every year that we've looked back at, it's been the same. So we do think that this is a very clear finding. We're going to be looking back at the last 10 years of NELA data to really drill this down and try and work out if there is any cause for it. Did we look at the differences in, it says morality, but I don't think they mean that. I think they mean mortality between females and males. Dave?
So I've written down on a piece of paper because I can't remember if we looked at that, and I've got a feeling we didn't. Because don't forget, this isn't a standard of care. Really, we're not allowed to do analysis that isn't part of a audit process. Well, that's weak to say we're not allowed. We need to look at that. I don't know the answer. I'm sorry.
I think we could drill that down, can't we, when we look at this?
Yeah.
So we are really limited in what we can put into the report because it has to relate to the audit standards. But as you can imagine, when you look at a massive data set like this, you do pull out things that are of interest. And then we try to look at those in terms of subgroup analyses at various points over the year. But this is something that's crept back again and again. Edwin, I'm sorry, Dave, you said going to say.
No, all I was going to further about the bit that always crops up is for female and male patients is the sort of gynae confounding differential diagnosis. But if you look in the report, what we have done is sliced it up by different age bands for males versus females, and the phenomenon of taking longer to get to theatre if you're female is applied through all of those age bands. So this isn't something about, it might be they're in labour or they need a pregnancy test before you're allowed to do a CT scan. It's not that. There is something else going on. I suppose part of the problem is NELA isn't research, so it's not been designed and it cannot answer some of these questions. All we can really show is these association. It's the starting point for some research, isn't it, to find out what is going on. We can try and slice it up a bit more, but with our existing data set, we may not be able to answer the question.
Okay. Is it important?
Well, that's why we need to look at the mortality outcome, because I feel amiss that we didn't look at that. I don't know if we did look at it, but it's not in the report. I can't remember if it was one of the analyses. Okay. Is it important? Yeah, I think it probably is important.
Yeah, I would agree with you. Whatever it may show.
Yeah.
Okay. So I haven't got any more questions that have come in specifically around health inequality. While I answer the last few questions that are in the Q&A, could you put into the Q&A, everyone that's still dialed in, and we've still got 102, any analyses that you would like to see in year 11 that we haven't seen in year 10? Either put it in the Q&A now or send it by email. But if there's a burning question or something that you would like to see, please let us know. Why is BPT not reported on within the annual reports?
As in compliance with the BPT, I suppose it's a completely separate process. BPT is overseen by NHS England. It's the financial negotiating is done between commissioners and healthcare providers. The data is supplied by NELA. It's produced, is it quarterly? Eamon, our data analyst, produces those summary reports that is used by commissioners to make a judgment of whether or not the payment should be made. It's not, so I suppose it's unnecessary to include it in the report because it's out there in the public domain.
We have tried though, haven't we, to find out exactly what happens to our data and who gets paid still on a block contract and all those other things. So we did a mail out, didn't we, to all of the organisations recently to find out what was happening with BPT. And we got some replies, but not all replies. My own organisation didn't reply.
No, I mean, the truth is, as far as I can understand it, I don't know if it's all, but everywhere I ask is that emergency surgical admissions remain on what's called a block contract. So there is no payment by results for emergency surgery. So there's two different bits of NHS England are not really talking to each other. There's one department describing best practice tariffs and another department that says no, contracting remains as a block contract.
Yeah.
That doesn't mean that I think hospitals will be struggling to receive the enhanced payments at the moment. But that doesn't mean that the topic is not equally worthy of importance, and the reputational benefit for meeting those standards and benefits for your patients should not be forgotten. But I'm not sure that any hospitals are able to access enhanced payments. In fact, let us know if you're listening to this and you know that you've, because I think for our hospital, this is £250,000 a year. Because we do meet the standard, and I would like that money to come. So if you're a hospital that is receiving the best practice tariff related to specialist care for older patients, please send us a message. I'd like to know.
Okay. Debbie has said comparison with NOLAP numbers would be interesting. Do units with high mortality turn down less cases? I do think that this may be a phenomenon that we see as we move forward in time. So I think NOLAP is, or the concept of NOLAP, within the care of emergency laparotomy or acute abdominal pathology patients is becoming more accepted. And I do wonder whether we're going to drive down our mortality rates because we've got some different type of decision making going on. Hannah, the PowerPoint probably won't be available as a PowerPoint, but it will be available in the webinar, so you can screen grab what's on the slides so that you can add your own data for your own local presentations. David Griffiths has made a comment about MFA. I think that's like we call it 2FA, the multi-factor, the two-factor authentication. That is a major problem and will significantly impact data input. We've not really seen that, have we, at national level? Since we've had 2FA, we haven't seen that there's been a drop-off in data input. So although it's a bit annoying, it's something that we can't avoid, and we haven't seen a data drop-off, which is good. Right, we are now on 12:58. People are coming through with some nice ideas about other analyses that we can do, so we'll make a note of all of those. Fawaz, who is actually my medical student, is dialed in, and he has raised the point of the data analysis that we were talking about for a fellow doing, Dave, which is around which specific elements do we know are most strongly associated with lower mortality rates, and that's a piece of work that we're going to be doing, isn't it? So
yeah, very difficult question to answer succinctly. Well, I suppose I can. No, we don't.
We don't know, but well done, Fawaz, for answering the question. For asking the question. Okay, right. We're now on 12:59, so we're about to be kicked out of this Zoom meeting. Thank you so much for all of your engagement and all of the questions that you've popped in the box. do email us at the email address if you've got anything else that you'd like to ask us or suggestions for the future. We are very open to anything that you suggest. I haven't got anything else to say, and I think that we will wrap it up there if that's all right with everybody. So thanks very much for joining, and thanks, Dave, for a brilliant presentation.
No, thank you for your attention. Get in touch.
All right. See ya.